Hi, hello everyone. Welcome to Dr. Ravichandra official. In the previous video, we have discussed what are all the investigations that are to be done for a case of a hemolytic anemia. Now, in this video, we will discuss the various causes of hemolytic anemia. As I said earlier, anemia is broadly classified into anemia because of the blood loss, because of the decreased RBC production, and because of the increased RBC destruction. In the increased RBC destruction, it results in hemolytic anemia. It can be hereditary and acquired. Hereditary conditions, abnormalities of red cell membrane, they are hereditary spherocytosis, hereditary elliptocytosis, or hereditary ovalocytosis, hereditary stomatocytosis. Disorders of red cell interior, red cell enzyme defects, also called as enzymopathies. There are defects in the hexose monophosphate shunt pathway, that is G6PD, glucose 6 phosphate dehydrogenase deficiency, and there are defects in the Embedden Meyer Hoff or glycolytic pathway, that is pyruvate kinase deficiency. Disorders of hemoglobin, also called as hemoglobinopathies, structurally abnormal hemoglobins such as sickle syndromes and other hemoglobinopathies. Reduced globin chain synthesis called as thalassemias. Coming to the acquired conditions, antibody mediated, that is immunohemolytic anemias, which include autoimmune hemolytic anemias, drug-induced hemolytic anemias, and isoimmune hemolytic anemias. Autoimmune hemolytic anemias can be further subclassified as warm antibody autoimmune hemolytic anemias and cold antibody autoimmune hemolytic anemias. Acquired causes of hemolytic anemia under mechanical trauma, microangiopathic hemolytic anemia or MAHA. Direct toxic effects results in hemolytic anemia in conditions such as malaria, bacterial infections, and other causative agents that will show their impact toxic effect on RBC causing the direct lysis. Acquired red cell membrane abnormalities, which is paroxysmal nocturnal hemoglobinuria. And the last condition, splenomegaly may also result in hemolytic anemia. So, hereditary, in this video, we will discuss the hereditary causes of hemolytic anemia. That is, abnormalities of red cell membrane and disorders of red cell interiors. First condition is hereditary spherocytosis, which is the common type of hereditary hemolytic anemia, and it is a autosomal dominant inheritance. In these, the red cell membrane is abnormal. Coming to the pathogenesis of hereditary spherocytosis, actually there are membrane cytoskeleton proteins, or skeleton is made up of some proteins which will lie closely opposite to the internal surface of the plasma membrane, and they are responsible for the elasticity and maintenance of the RBC shape. These membrane skeleton are made up of spectrins, ankyrins, bandform 3, bandform 4.1, and bandform 4.2. Coming to spectrin, it is the chief protein component responsible for the biconcave shape, and it has two subunits, alpha unit and beta unit. Ankyrin and bandform 4.2 will bind to spectrin to band 3, and the band 3, which is a transmembrane ion transport protein. Band 4.1 will bind spectrin to glycophorin A, which is a transmembrane protein. So, pathogenesis. The mutation most commonly involve the gene coding for ankyrin will be more than band 3, then spectrin, then band 4.2. Band 4.2 is also called as paladin. Most common defect in hereditary spherocytosis is ankyrin, and most common defect in hereditary elliptocytosis is spectrin. So this can be asked for a MCQ or in a NEET exam or in the Viva they may ask you the most common defect in hereditary spherocytosis is the answer is ankyrin, and the most common defect in hereditary elliptocytosis is spectrin. So pathogenesis mutation will lead to loss of membrane cytoskeleton proteins ankyrin or spectrin or band 3 and 4.2, thereby causing the reduced membrane stability, which results in spontaneous loss of membrane fragments during exposure to the shear stress, thereby loss of membrane relative to cytoplasm, and ends up in which will forces the cell to assume smallest possible diameter for a given volume. As a result of this, the cells become more and more spherical, or cells become microspherocytes. RBCs become less deformable. So it is unable to pass through the membrane. So gets trapped in the spleen as they are unable to pass through the interendothelial fenestrations of the venous sinusoids. And these RBCs are phagocytized by the reticuloendothelial system, which will result in extravascular hemolysis because the hemolysis is happening outside the blood vessel. So this is a picture showing the pathogenesis, primary membrane skeletal defect resulting in decreased membrane stability, thereby membrane loss, and decreased surface to volume ratio resulting in spherocytosis, and there is decreased deformability. As a result, there will be splenic trapping and there will be erythrostasis resulting in decreased glucose and decreased pH, which will end up in phagocytosis, thereby causing extravascular hemolysis. Laboratory findings: extravascular hemolysis is seen. So there will be mild to moderate chronic anemia. There will be increased reticulocyte count because of the bone marrow response. There will be unconjugated or indirect hyperbilirubinemia. Splenomegaly will be there. And the characteristic feature of hereditary spherocytosis is the mean corpuscular hemoglobin concentration will be increased due to dehydration caused by the loss of potassium and water. And there will be spherocytes. Peripheral smear shows microspherocytes, which are small RBCs without central pallor. Actually, we know that normally there will be central one-third pallor present in a red blood cell. Here, there will be no central pallor. As a result, MCHC is increased. You can appreciate that in the picture shown. Coming to the osmotic fragility test or pink test. It is helpful in testing the spheroidal nature of red cells, which will lies more readily in solution of low salt concentration. That is, osmotic fragility will be increased. We have to take 12 test tubes with different concentrations of sodium chloride, and the blood drop is added to each sample, and you have to note down the hemolysis starting point, and thereby you can note the osmotic fragility. Autohemolysis test. It is similar to the osmotic fragility test, and it is done after incubation, and it shows increased spontaneous autohemolysis, that is 10 to 15% of the red cells as compared to normal red cells less than 4%. Direct Coombs test or antiglobulin test is negative. So it is useful to distinguish the conditions of other spherocytosis, that is acquired spherocytosis, which is seen in autoimmune hemolytic anemias. So spherocytes are seen in hereditary spherocytosis and autoimmune hemolytic anemia. By doing a direct Coombs test, you can differentiate a hereditary spherocytosis and autoimmune hemolytic anemia. Direct Coombs test or antiglobulin test is positive in autoimmune hemolytic anemia. Autoimmune hemolytic anemia is the most commonest cause of spherocytosis. Treatment for hereditary spherocytosis is splenectomy. Splenectomy is almost always beneficial in hereditary spherocytosis. After the splenectomy, anemia will be corrected, but still the spherocytes will remain in the blood. You have to vaccinate against the encapsulated organisms like pneumococcus and Haemophilus influenza. So next condition that we are going to discuss is enzymopathies. Enzyme deficiency causing hemolytic anemias. One is G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency, pyruvate kinase deficiency, aldolase deficiency, hexokinase deficiency. So in the exam, if they give all the four options, all are correct only. So they will give the question as enzymopathies include G6PD deficiency, pyruvate kinase deficiency, aldolase deficiency, hexokinase deficiency, all the above. The answer is all the above. Glucose 6-phosphate dehydrogenase deficiency. This is a X-linked recessive disorder. Hereditary spherocytosis is autosomal dominant disorder, whereas glucose 6-phosphate dehydrogenase deficiency is X-linked recessive disorder, and it is characterized by hemolytic anemia on exposure to the oxidative stress. Pathogens is normal red blood cells are protected from oxidant injury with the help of reduced glutathione. The things that are causing oxidant stress are the causes for oxidative stress are viral and bacterial infections, certain drugs usage like antimalarials, primaquines, sulfonamides, nitrofurantoin, aspirin, vitamin K, and in conditions of metabolic acidosis and ingestion of fava beans, which is called as favism, will result in oxidant stress, thereby causing hemolytic anemia in G6PD deficiency. Favism can be asked for a 3 mark question or a 1 mark MCQ. Ingestion of fava beans will result in favism. So, as we studied in our biochemistry class, that glucose is converted to glucose 6-phosphate with the help of hexokinase enzyme, and this glucose 6-phosphate is converted into 6-phosphogluconate with the help of conversion of NADP to NADPH in the presence of glutathione reductase. The glutathione is reduced, and the glucose 6-phosphate is converted to phosphoenol pyruvate with ADP generation with multiple enzymatic steps, and in the last step phosphoenol pyruvate is converted to pyruvate with the help of pyruvate kinase. This total cycle is called as Embden-Meyerhof glycolytic pathway, whereas glutathione reduction is comes under hexose monophosphate or HMP shunt pathway. So the conversion of glucose 6-phosphate to 6-phosphogluconate. If there is G6PD deficiency, there will not be any reduction of the glutathione. So for easy understanding, I made a chart what is going to happen in a normal person and in a G6PD deficient patient. Normal person, if there is a oxidant stress because of various causes, as there is glucose 6-phosphate dehydrogenase, there will be NADPH generation in HMP shunt pathway. As a result, the glutathione is reduced, and the reduced glutathione will protect the RBCs from this oxidant injury. As a result, there will be no hemolysis. But in the case of G6PD deficiency, glucose 6-phosphate dehydrogenase enzyme deficiency, When there is oxidant stress, NADPH is not generated in the HMP shunt pathway. As a result, glutathione is not reduced. As there is no reduced glutathione, RBCs are not protected from the oxidant injury. It will result in hemolysis. If this hemolysis occurs in the blood vessel, it is intravascular hemolysis. And if it is happening in the outside the extra blood vessel, then it is extravascular hemolysis. So in G6PD deficiency, both intravascular and extravascular hemolysis will occur. Types of G6PD deficiency. It can be type 1, type 2, type 3. Type 1 is mildest form, type 2 is moderate form, and type 3 is most severe form. Lab investigations for glucose 6-phosphate dehydrogenase deficiency. There will be intravascular and extravascular hemolysis. So the bilirubin, serum bilirubin unconjugated or indirect bilirubin will be raised. There will be raised urine urobilinogen, raised fecal stercobilinogen, serum haptoglobin, which is a globulin binding protein, will be reduced or absent in G6PD deficiency. The LDH, plasma lactic dehydrogenase enzyme, will be raised. There will be evidences of intravascular hemolysis in the form of hemoglobinemia, methemoglobinemia, hemoglobinuria, methemoglobinuria, hemosideruria. And in the bone marrow response, there will be increased reticulocyte count, that is, reticulocytosis will be seen. Hinge bodies are precipitated forms of denatured hemoglobin in RBC, and these hinge bodies can be revealed with the help of using supravital dyes or supravital staining. That is, the dyes will help you to see the cells in live form. So, hinge bodies are characteristically seen in G6PD deficiency. Bite cells are formed because of the splenic macrophages eating these RBCs to remove this hinge body. So, bite cells are characteristic feature of G6PD deficiency, which will result in intravascular and extravascular hemolysis. Coming to the next condition, that is hemoglobinopathies. As all of us know, hemoglobin can be adult hemoglobin, which is called as hemoglobin A, fetal hemoglobin, that is hemoglobin F, or there is a minor part of hemoglobin also called as hemoglobin A2. Hemoglobin A is made up of 2 alpha chains and 2 beta chains. Fetal hemoglobin is made up of 2 alpha chains and 2 gamma chains, whereas HbA2 is made up of 2 alpha chains and 2 delta chains. In a normal adult, the blood will contain 96% of the hemoglobin A alpha to beta 2 and 3.5% of hemoglobin A2, 3 to 3.5% of HbA2, that is alpha to delta, and small amounts of fetal hemoglobin, that is alpha to gamma. Hemoglobinopathies. They are classified into qualitative disorders and quantitative disorders. In qualitative disorders, there is structural abnormality in the synthesis of hemoglobin, and they are called as sickle cell syndromes. In quantitative disorders, there will be quantitative decreased globin chain synthesis of hemoglobin. These are categorized as thalassemias. So, sickle cell syndromes are qualitative disorders of hemoglobinopathies, and thalassemias are quantitative disorders of hemoglobinopathies. This can be given in MCQs, or can be asked in Viva questions. If they are asked which type of hemoglobinopathy is seen in sickle cell syndrome, it is a qualitative disorder. Thalassemias are quantitative disorders of hemoglobinopathies. Sickle syndromes. Sickle syndromes are autosomal recessive disorders. Due to the presence of sickle hemoglobin in the red blood cells, the red cells with HBS will develop sickling when they are exposed to low oxygen tension. Sickle syndromes have the highest frequency in black race people and in Central Africans where falciparum malaria is endemic. This can be in three different forms: heterozygous state, that is sickle cell trait; homozygous state, that is sickle cell anemia; and double heterozygous state, that is sickle cell C disease or sickle D disease. Coming to sickle cell trait, heterozygous state is benign. In this, only one abnormal gene is inherited from the parent. These patients have no anemia and have normal appearance of red cells. In hypoxic crisis, this sickle cell crisis will develop. Sickle cell anemia or homozygous state. In this, abnormal gene is inherited from each parent. Sickle cell trait, only one from one parent. Here, abnormal gene is inherited from each parent. So, sickle cell anemia is a severe disorder associated with protein clinical manifestations and decreased life expectancy. The hemoglobin consists of the genes are present on chromosome 11, beta globin gene. There will be a mutation in this chromosome 11, which is a single point mutation at the sixth position of the beta globin chain, which is a nonsense or missense mutation. You can call it as missense mutation, okay, or point mutation. As a result of this missense mutation in the sixth position of the beta globin chain, there will be a substitution of valine residue for a glutamic residue. That is, glutamin is replaced by valine. As a result, hemoglobin S or sickle hemoglobin will be formed instead of hemoglobin A. So normal beta globulin, there will be glutamic acid, whereas in mutant beta globin, there will be valine. The change in amino acid sequence will cause hemoglobin molecules to crystallize when oxygen levels are low in the blood. As a result, RBCs will get sickled and get stuck in the small blood vessels. You can see the normal red blood cells and how the sickle red blood cells see in the picture shown. Deoxygenation of hemoglobin S containing red blood cells or results in deoxygenated hemoglobin S or sickle hemoglobin. Polymerization of deoxygenated HbS. There will be elongated rod-like polymers, and these elongated fibers will align and form aggregates, thereby distorting the red cell into classic sickle shape, which is called as sickling. Sickle cells will express higher than the normal levels of adhesion molecules, and they are abnormally sticky. As a result, there will be vaso-occlusion of the microcirculation, especially in the bones, lungs, spleen, and penis. So vaso-occlusion is seen in bones, lung, spleen, and penis. This can be asked in MCQs. So this is a picture showing how a normal red blood cell will be seen and abnormal sickle cell, which is sticky, can be seen. Sickling of the red cell is reversible initially with oxygenation. So when the hemoglobin is exposed to oxygen, the sickle cells convert back to normal. HbS depolymerizes and RBC shape will normalize. But with repeated episodes of the deoxygenation and sickling, the membrane damage will occur permanently. and the RBCs become irreversibly sickled. That is, they will retain their normal sickle shape even when fully oxygenated. Irreversible sickle cells have rigid, non-deformable cell membranes that leads to difficulty in passing through the splenic sinusoids. As a result, there will be splenic sequestration and followed by rapid phagocytosis, which will result in hemolysis outside the blood vessel, that is extravascular hemolysis, resulting in hemolytic anemia. With membrane damage, water comes out of the cell, resulting in intracellular dehydration, and there will be increased MCHC. So, increased MCHC is also seen in sickle cell anemias. Reversible sickle cells are responsible for vaso-occlusive symptoms, and the irreversible sickle cells are responsible for the hemolytic anemia. So, vaso-occlusive condition is a prior condition, and it can be reverted back when the sickle cells are exposed to again oxygenation. They will revert back, but this, if it goes on continuing, it will end up in irreversible sickle cells, thereby causing hemolytic anemias. So this is a picture showing how a hemoglobin A is converted to hemoglobin S because of the deoxygenation. The glutamic acid is replaced by valine because of the point mutations at the sixth position of beta globin gene on chromosome 11. There will be membrane changes, increased adhesiveness, increased RBC transit times in inflamed tissues, and there will be splenic sequestration. In the earlier stages, there will be microvascular occlusion. In the late stages, there will be hemolysis, congestion, and infarction of the spleen. Factors determining the rate of sickling. This can be asked for a 6 marks question or a 3 marks question. Amount of HbS and interaction with other hemoglobins. Most important factor for sickling is amount of hemoglobin S. In homozygous individuals, all the hemoglobin in red blood cells is hemoglobin S and undergoes sickling. In heterozygous conditions, only 40% of hemoglobin is HbS. Sickling does not occur because HbA, which is remaining 60% of the normal hemoglobin, has an inhibitory effect on polymerization of the HbS. Fetal hemoglobin also has inhibitory effect on sickling of the hemoglobin S. Newborns do not manifest the disease until they are 5 to 6 months of age, when the amount of hemoglobin F in the cells falls close to the adult level. So, fe fetal hemoglobin is present up to 6 months. So, there will not be any sickling seen in these patients or children. After the 6 months, they may show the symptoms of sickle cell anemia. Hemoglobin concentration of the red cell. Hemoglobin concentration of the cell, which is also called as mean corpuscular hemoglobin concentration, which is raised, will affect the polymerization to a great extent. So, greater the MCHC, greater will be the sickling. Intracellular dehydration. Intracellular dehydration increases the MCHC, which will facilitate the sickling. Conditions that decrease MCHC. When sickle cell anemia occurs with alpha thalassemia, there will be reduced sickling. So, alpha thalassemia combined with sickle cell anemia, sickle thal, will result in reduced sickling. Decrease in pH, that is acidosis, reduces the oxygen affinity of the hemoglobin. Thereby, there will be increase in the fraction of deoxygenated hemoglobin S, which will facilitate the sickling. The length of the time red cell exposed to low oxygen tension, that is, the organs having slow or sluggish circulation like bone and spleen, have an increased risk of sickling. So this is a diagrammatic picture showing the basic molecular defect, that is glutamic acid is substituted by valine at the sixth position of the hemoglobin gene on chromosome 11, which is a point mutation, and there will be polymerization, and as a result there will be sickling. Clinical features of sickle cell syndromes: there will be anemia and vaso-occlusive phenomena. Anemia. Irreversible sickle cells have rigid, non-deformable cell membranes that will lead to difficulty in passing the splenic sinusoids. There will be sequestration and rapid phagocytosis. Anemia is associated with jaundice and reticulocytosis. So, in sickle cell anemias, remember JAS. There will be jaundice, there will be anemia, there will be splenomegaly, and there will be reticulocytosis. Vaso-occlusive phenomena. Reversible sickle cells express the higher than the normal levels of adhesion molecules, and they are abnormally sticky. So results in occlusion of the microcirculation, especially as I said earlier, five: bones, lungs, spleen, and penis. Vaso-occlusive symptoms are the most common manifestations of sickle cell anemia. In the bone, there will be dactylitis, that is inflammation of the bones of the hands and feet, also called as hand-foot syndrome. There is increased chances of Salmonella osteomyelitis. There may be increased chances for avascular necrosis of femoral head. Fish mouth appearance of the vertebra due to occlusion of vertebral arteries is seen. There will be prominent cheekbones, and there is clear cut appearance or hair and appearance of the skull. In the exam, they may ask you fish mouth appearance of vertebra is seen in sickle cell anemias. Crew cut appearance of skull is seen in sickle cell anemias. Hand foot syndrome is because of hemolytic anemia because of sickle cell formation. Acute chest syndrome is characterized by cough, fever, and chest pain. There may be seizures or stroke because of this sickle cell anemia, and leg ulcers will be seen. Stagnation in the corpora cavernosa leading to priapism. So this is because of vaso-occlusion, because of the sickling. Spleen. In the initial stages, there will be splenomegaly due to congestion and trapping of the red cells in the vascular sinusoids. As a result, gamma antibodies will be formed. Gamma antibodies can be asked for a 3 marks question, or in the MCQs they can ask you. Gamma antibodies consist of foci of fibrosis having iron or calcium salts deposited in connective tissue. Prolonged hypoxia and infarction can lead to autosplenectomy, which increases the susceptibility to infection with capsulated organisms like Haemophilus influenza, pneumococcus. Aplastic crisis. Aplastic crisis can be asked for 3 marks question. In sickle cell syndromes, you will see two types of crisis. One is vaso-occlusive crisis, and the other is aplastic crisis. Aplastic crisis occurs from the infection of red cell progenitors by parvovirus B19, which will cause a transient cessation of the arthropoiesis and a sudden worsening of the anemia. So, aplastic crisis is because of the parvovirus B19 infection in the red cell progenitors in sickle patients. So this is a beautiful picture showing various conditions that are seen in a case of sickle cell anemia. There may be stroke or retinopathy, anemia, aplastic crisis, infections, acute chest pain, acute abdominal pain, splenic atrophy, hematuria, priapism, chronic leg ulcers, ischemic necrosis or avascular necrosis of bone. This is a peripheral smear picture showing the sickle cells. You can appreciate the target cells also. Sickling test. It is a method where a sample of venous blood or capillary blood is collected and the venous blood from the arm is collected. Capillary blood from the fingertips or earlobes and in infants from the heel of the foot can also be used. Mixing this blood with a reducing agent like sodium metabisulfate will induce sickling in susceptible cells. So, in the exam, they may ask you the chemical that is used for sickling is. In the options, there will be sodium metabisulfate. You have to mark it. 1% sodium metabisulfate is helpful in inducing the sickling in susceptible cells as it is a reducing agent. The sickling can be seen or under the microscope after waiting for a 20 minutes. This test is very simple and quick, used to identify the presence of hemoglobin S. Positive sickling test associated with a normal hemoglobin is likely to indicate a patient with sickle cell trait. Screening for sickle cell anemia. Sickling and solubility tests are used for screening. Hemoglobin electrophoresis. Hemoglobin S moves slowly towards the anode, whereas the hemoglobin A will move faster towards anode. This will helpful in identifying a sickle cell trait and sickle cell anemia. So hemoglobin electrophoresis will be very much helpful in diagnosing a sickle cell trait and a sickle cell anemia. You can appreciate how the HbS is represented in a sickle cell trait and sickle cell anemia. Patients with hemoglobin S are relatively protected against falciparum malaria. This can be asked in the 3 marks question or MCQs or in the practicals Viva. The two reasons are first one, malarial parasites consumes oxygen and decrease intracellular pH. So acidosis will promote sickling in these red cells. And these distorted red blood cells are cleared rapidly by the phagocytosis in the spleen and liver, and this will result in parasitic load reduced or parasite load is down as it is removed there and then. The second reason is normally malarial parasite forms membrane knobs containing a protein PFEMP1, that is Plasmodium falciparum EMP1. These membrane knobs help in adhesion of infected red cells to endothelium. Sickling impairs the formation of membrane knobs. That's why the patients with hemoglobin S are relatively protected against the falciparum malaria because of the acidosis and because of the formation of membrane knobs. Conditions that provide protection against malaria are this can be asked in Viva or in MCQs or in entrance examinations. Remember, first one is G6PD, that is glucose 6 phosphate dehydrogenase deficiency. Second is alpha and beta thalassemias. Third is sickle cell disease. Fourth is absence of Duffy antigen. Fifth is pyruvate kinase deficiency. And sixth is HPC. There are two enzymopathies, G6PD and pyruvate kinase deficiency, alpha and beta thalassemia, sickle cell disease, absence of Duffy antigen, and HBC, hemoglobin C. These are the conditions providing protection against malaria.